20 hours or so, people get a lot more symptoms and side effects and feel miserable. When we directly ask question to patients in both groups, that you have it this way, this is the other way of doing it, which way would you do it? And majority of the patients in both groups said, we prefer to take it same day in the morning, have a colonoscopy in the afternoon. We don't want to do the other way. And they had experience of the other regime. So our conclusion was same-day dosing of Picolex is far superior and is preferred over the split dose of Picolex. So I think we move in closer and closer and closer to the colonoscopy, the time of taking the bowel prep. And that is the direction of travel I feel we are going. There's been ESG guidelines issued recently, and I think Brian was involved in that. And I would strongly recommend you reading these guidelines because lots of practical references there. But there was some very strong recommendation which very clearly said that split dose or same-day regime of 4-liter PEG solution for afternoon colonoscopy for routine bowel prep. That's what they suggested. That's how we should be doing most of our practice. Also, interestingly, I was quite proud. They also looked at our study and said split dosing or same-day regime of Picolex also works. So it's not just PEG, but it's also Picolex that you can take the same day in the morning, and it's very effective and it's valid alternative for elective outpatient colonoscopy. The rest of the things I won't go into details. They're very simple and basic. And once you've got all this sorted out and you've got perfect bowel prep, this is the reason why we're doing bowel cancer screening, to prove to everyone that right-sided colonic mortality can be reduced. These subtle serrated lesions, you'll hear a lot today, later on by various experts. You're not going to find them unless you address your bowel prep. You saw how subtle that lesion was. Its finding is a nightmare. Once you find it, removing them is a nightmare. And I almost invariably now, when I find an SSP, I always resect it this way. I find it works a lot. I've struggled a lot with snare. They produce a lot of mucus. They are very, very thin. The snare just slips. And there was a recent data which showed very clearly inadequate polypectomy. One of the risk factors was sessile serrated polyps. It's just because they're so subtle. Once you have diathermy artifact introduced in there, it's very difficult to figure out where the margins are. So I think this works. All you have to do is good lift, a circumferential incision, dig your snare in, it always catches, it doesn't slip. And although it looks a bit tricky, but takes less time than a standard EMR. Yes, if you can get it into your snare, EMR is a lot quicker, and I wouldn't recommend